So we're going to be taking a rapid tour through the history of the provision of medical care in the U.S. We're going to describe its origins in this first session at the birth of the modern era and the advent of the scientific method. I'd like you to be considering, this is really ancient history, I know, but it's still relevant for America. I'd like you to be considering how this self-reliance of an agrarian society is incorporated into the myths that we see today, including from RFK Jr. and various other sources. And I'd also like you to consider, as physicians, how society respects your knowledge and your provision of care in reference to how care is delivered and improved, and to consider whether the recent problems with respect of knowledge and elite, quote unquote, perspective is affected by whether you're actually able to deliver your care in a society where medical insurance is not available. We'll certainly touch on the AMA's role in professionalism and racism as well. So let's talk a little bit about the origins of medical care in the mid-1800s and early 1800s, colonial days. Doctors were still following an anecdotal, apprentice-based method of training. We used Galen's four humors. Anybody know those four humors? Black bile and white bile and blood and etc. Here's Betty. So Betty may have something to say. I don't know. Betty, you're joining us? Well, anyhow, so medical care was minimal. Sorry, medical training was minimal. It was 2 years of formal medical training. Again, typically working with a doctor and learning what that doctor happened to do. Physicians struggled financially. They held little status, and they competed for patients and revenue. They were considered professionals, so they did have at least that societal respect. But their management of the patient's care was, of course, quite poor. The profession was divided, weak, and ineffectual in raising standards of care, and it was at odds with families' experience with taking care of serious illness in the home. And as we'll see, what we did to people would not necessarily make them better, although it would be a dramatic effect on their physiology. So many families would treat patients better with grandma's care than what we could do as physicians. So we would clearly alter homeostasis. We had the poisons to induce vomiting, cause diarrhea, and bleed by leeches or the high technology of new phlebotomy techniques. And we could drain, pints of blood from a patient at one moment, and they could certainly feel its effects. So they might respect us in that regards. However, really, natural observations of Native Americans and grandma's observations of how to get kids through measles and kids through bacterial infections was often more effective than our interventions. And there's I mentioned this in the video. Anybody read the book Hamilton? Uh, During the creation of the Constitution, folks joined. There was a yellow fever outbreak in Philadelphia, which killed actually thousands. And some of the attendants at the Constitutional Convention and the events happening in Philadelphia were affected by the mosquito-borne yellow fever, many of whom were seriously set back by phlebotomy and interventions. The physician of the day would bleed the patient 3 times a day, induce vomiting 3 times a day, and somehow the patient might survive the yellow fever and our interventions. Alexander Hamilton was lucky enough to have a friend he knew in St. Croix, where he was born in St. Kitts, but down in the Caribbean, who had seen lots of yellow fever. and instead gave patients tincture of opium at bedtime and lavender to help them sleep, make sure they had adequate hydration, and he got through it relatively unscathed, unlike some of his colleagues and other Philadelphia residents. So these hospitals of the day also certainly were not modern citadels of care. They housed destitute, chronically ill, homeless, or insane. They were funded by religious groups or charitable groups, and they were places of last resort, often also for those who were poor and in debt. So this it was relatively heroic medicine. These are the modern breakthroughs in phlebotomy care demonstrated on the right of that slide. That's Benjamin Rush, who signed the Constitution. These were some of the magic oils and panaceas for various disorders. So if this was the state of medical care, really into the mid 1800s, people really didn't need medical insurance, in part because care was inexpensive. It didn't affect many people who would forego seeing the doctor. What was really needed was income stabilization if someone became ill. So there were ways to amputate if someone got their arm caught in industrial machinery, or a family was bereft of their father and a widow needed income. These were the forms of insurance that were necessary. So what was really needed was medical insurance. So this you didn't miss much. Basically, we discussed about the limitations of medical care and the necessity for income provision if someone was disabled or killed. And by the way, there was a long-standing tradition in Europe of having, in Germany, what were called sickness funds, in Britain, what were called friendly societies, basically guilds of silver workers or carpenters or various forms of working that were set up to provide support to widows or families if someone was disabled. There is a history in Europe, but not in the United States. And those sickness funds were to be a framework by which medical coverage was expanded in the coming century. And they did not exist for the most part in the US. There were a few benevolent societies in the United States, but not a lot. Some of them were actually immigrant society groups from Sweden or elsewhere. But they had a lesser role in terms of providing coverage for a destitute family whose worker was injured or killed. And again, what was happening in society at the time was these conceptions of self-reliance, this sort of idolized conception of pulling yourself up by your bootstraps, and which was somewhat in variance with more of a community perspective in Europe. And again, folks can challenge me if I'm wrong on this or bring your own thoughts to this, but I think there is some evidence to this. So what happened in the mid 1800s was the development of accident insurance, funeral insurance, and life insurance. They first developed among workers who were on the railroads and steamboats, and then became more generalized. What else was happening during this era, of course, was the scientific method. So concepts of cell and germ theory were being advanced by Pasteur and Koch later in the century. Anesthesia was first used by William Morton for surgery, which made a dramatic effect, obviously, on care. Aseptic technique, first looked at by Semmelweis in Germany, who was felt to be crazy with his theories, became more accepted. And advances in medicine and surgery led to necessary reforms in medical education. Should also mention that Florence Nightingale took a comprehensive and organized approach to nursing during this time and hygiene. So germ theory and antiseptic techniques were advancing throughout the course of the century. As a consequence, and most of which was developing in Europe, as a consequence, the US started to embrace the European model. So where previously you'd spend 2 years anecdotally working with a physician in the field or the office, the concept of underpinning clinical education that you guys are doing now with basic bioscience started to be unveiled. Anatomy pathology first was expanded both in those days, and schools like Johns Hopkins and elsewhere actually affiliated with the universities where research was being done in biology. Training expanded to 3 years, the academic year expanded to 9 months, and residency training was developed. So all of this was happening in a society that had previously viewed physicians as inept, perhaps necessary, but often ineffective, and the scientific method was giving rise to the sovereignty of the medical profession. Hospitals during this, and hospitals were also changing their designation as sick houses for the poor and insane to basically um, citadels of modern care. And charity hospitals and public hospitals became commonplace. In Boston, there was Boston City Hospital. In Philadelphia, there was Philadelphia General Hospital. Every hospital had its charity programs. Many of these same cities also had elite hospitals paid for by the wealthy, such as MGH or Pennsylvania Hospital. But during this era, again, medical care only took a fraction of one's salary, and it was paid for by out-of-pocket payments. If you were poor, however, you exchanged your care for providing your clinical material, quote unquote, to the training clinicians. So here's a picture of Pennsylvania Hospital in Philadelphia. Here's a picture of the wards of Philadelphia General Hospital. And this division between how care was provided to the poor versus the wealthy expanded into your training and colors how we do medical training in the U.S. So essentially, homeopathic medicine was evident at the time. Naturopaths were very popular and often providing effective forms of therapy, maybe pioneered by the Native Americans, but with the scientific method, allopathic medicine or osteopathic medicine, which developed actually, I think, 10 or 15 years later, were becoming well accepted. Um, However, also during this time, the American Medical Association reorganized primarily to protect the interests of physicians at a time when there were many changes happening. And it was recognized that there was huge disparity in how medical care was being provided in the US. Yes, you had Johns Hopkins, you had other, same University of Washington or elsewhere, but you also had many smaller and often rural medical schools that did not embrace the scientific method. There was no standardization in prerequisites, and there was nothing in the way of state medical licensing. The Flexner Report of 1910 really did come out and shake things up and had the effect of standardizing medical training and improving and protecting the public from folks who are using non-scientific based care. The American Medical Association, although its primary interest was protecting physicians, also had a role in protecting patients. So it did assume control of licensing and medical education, and in doing so, gained greater power and respect. So allopathic medical care was expanding its legitimacy, its prestige, and its authority. Again, we talked a little bit yesterday. I showed you the pictures of Marcus Welby, MD, on the television. And in your lifetime, you may not have experienced how physicians were respected. Let me ask you, let's take a short break. In your lifetime, when you view the respect for physicians in society, there's been so much about elite about how the elite are screwing the working man and the like just in the past 20 or 30 years. When you guys view prestige of physicians, allopathic or homeopathic, osteopathic medical care, what are the connotations that come to mind? I'm going to put you to work, folks. So
Um,
I was born in a different era. Caitlin, and thank you. And I'm comfortable with people shouting out, but I'm fine with raising hands. I can see you all as well. Caitlin, yes.
um, so when I think of the current state of allopathic and osteopathic medicine, there's definitely the prestige that you were kind of hinting at. In current day, there's prestige that comes with your position, and people, it's kind of well regarded in society as a profession and generally looked upon as having a lot of knowledge and also care for the community. So it was interesting in the reading that you gave out how it started off as almost an illegitimate almost practice. So it's interesting because I never considered that before.
Sure. And I think an important take-home message is one should not take it for granted that physicians and the care that we provide will be respected. And I think we've seen during COVID, which is clearly in your lifetime, embracement of ivermectin and hydroxychloroquine and agents that are totally ineffective, coming from a different perspective. Actually, it's almost topsy-turvy now that we have scientific methods, non-scientific information. I've done my research, says my patient, is affecting perhaps to some extent how that legitimacy is viewed. Zachary, yes.
Um, at least growing up, my experience was more along the lines of like a necessary evil. So like having to, when my parents felt they couldn't manage sickness on their own, we'd go to an urgent care, try to get a visit with a primary care physician as a last resort, but very apprehensive to interact with physicians in general. So I don't know if that was just
No,
my
that's very
personal
helpful.
experience.
No, I appreciate that. And if I could drill down a little bit, the apprehension, is it around insurance and the bills that you'll have to try to pay off? Is it based? So it's not that. So,
No,
so
yeah,
share that more. That's so sure. Where is that apprehension?
Uh, yeah, dude, apprehension to listen. I think it was shrouded in like the elitism of like not understanding why they would recommend certain things. I think there was still a very paternalistic view in some of the pediatricians I had of just like, you need to do this. And if you don't do it, you're not taking care of your kid. My parents, I don't think, responded very well to that.
So thank you. And so that actually is very important in your careers as clinicians and doctors. Your experience with your parents relates to the lack of ability of some physicians to communicate with their patients and to be speaking on a plane that they understand, and perhaps even a lack of respect towards the patient as someone who is not on there's a discrepancy, an unequal plane in terms of knowledge base between a layperson and a physician. And that asymmetry can play a role in how people perceive that to some extent. There's maybe many other factors that play a role, right? But thank you. That's important. Therese, yeah.
I was just thinking that like I feel like there's like a growing like eat the rich kind of mentality in our culture right now, and but I feel like that typically applies to like CEOs in business and Wall Street, but I feel like doctors tend to be excluded from that. I feel like like physicians are still thought of as like good guys, even if like people recognize that there are certain people that make like millions. But I just want to say that.
I hope that persists. Thank you. And yeah, no question, I think various social circles will have various, but most of us are not billionaires. and most of us see the disparity in terms of income and the unfairness of this in our current oligarchy. We've so far been excluded, but perhaps not. I mean, depending on what you're reading and where your input is, I see a level of in this relatively pinkish now red state in terms of government. I see those in power, including RFK Jr., as having the physicians sort of enveloped in the eat the rich conception. So hopefully that will change. And I guess what I'm having you guys think about, one of the things that might change it is if we could deliver care more effectively by changing how people get their care, insurance-wise, if that makes sense. Um, Anyhow, by the way, so let's move on, unless there are other thoughts around this. Thank you. So I do want to touch base with the AMA. And again, racism in the United States and slavery are our original sin, and certainly play a role with many elements of society. I will share that the actual one of the first presidents of the American Medical Association was a fellow who was a plantation physician initially by the name of Sims. He actually was a local physician in the South, and then came to have an interest in gynecology and obstetrics. And again, in that era, there was these misconceptions that African Americans somehow were impervious to pain, somehow would be able to, quote, rise from childbirth more rapidly than folks who had different pigment in their skin, and was very aggressively performing surgery on unanesthetized patients who are often either slaves or made to work as domestics in his medical clinics. So there is a fairly tragic and cruel history that goes into some of the research done during the 1800s. There was again, the origin of the American Medical Association was going back to 1847. At the time, of course, this was prior to the Civil War, but some of the, quote, free states were provided the allowance to accept African American physicians, but few did. So what happened is the National Medical Society formed as a lobby for black physicians, but it was formally excluded from the AMA. And it became actually a medical association in 1895. One of the unfortunate outcomes from the Flexner report, which had positive effects in terms of medical care, but there were undersourced black medical schools that had to close because of its regulations. And that further excluded African American physicians from taking care of folks and their patients. Black doctors were excluded from the AMA medical societies, which was the only means for licensure and hospital privileges. And we'll see that that extended throughout the history of America for some time. And we'll revisit that in our conversations. So basically, during the 1800s, of course, the steam engines were created, huge advances in industry. As the 20th century progressed, medical care was assumed by the AMA. It gained power. As the need for medical care started to arise on a more consistent basis, surgery for appendectomies or whatnot, there were various proposals to provide health insurance. But the AMA, right from the get-go, opposed any kind of government role in the provision of medical insurance. It also initially opposed the direct employment of doctors by hospitals or insurance companies or large employers. Its primary goal was defending doctors' independence from the needs of industry. And as we'll see, that's changed a shitload. This is being recorded, isn't it? But I wanted to underplay how this dramatic protection of the physician's independence and ability to escape from burdens and barriers imposed by industry. Wow, has that changed since the 1980s? We were talking about this yesterday, as we've become providers rather than clinicians. So something to think about what may have played a role with affecting that. Um, um, so, um, Let me know when you guys, it's just been half an hour so far. Want to move on? All right. So the next section is going to be talking about how government in health insurance was expanded in Europe during the Progressive Era, which followed the Gilded Age, and identify some early types of medical insurance. And then we're going to move on to the Great Depression, failures of capitalism that the Great Depression actually demonstrated at that time, and touch on various models of nonprofit health insurance. So, ineffectuality in the agrarian nation resulted in limited legitimacy. Science changed all of that, and modern medical care changed that. The AMA was always in the process of preventing intrusions of government in the provision of health insurance or the business of medicine. And the need for disability and medical insurance started to change with the turn of the century. So we talked about income stabilization. This is just some workers in an industrial plant. You can imagine there's various belts moving and various hot steam engines and whatnot. People would often be injured. These traditional mutual benefit funds were easily adopted once there was federal insurance and various programs. What was happening in Europe, by the way, so people remember the Gilded Age. This was an age of the robber barons and really successful entrepreneurs who assumed vast wealth in the nation. Again, that's a good thing. We moved forward in terms of railroads, in terms of assembly lines, in terms of products. But the workers that we just saw, the disparity between the quality of their lives was pretty striking of the day. This was the case in Europe as well during the Industrial Revolution. And in Europe, unlike the United States, again, because of the organization of labor, there was embracing of Marxist philosophy. Karl Marx talking about the proletariat and the necessity for labor to demand its own rights. There was subsequently labor unrest in Europe, an organization of socialist parties in Germany and England, and they were really butting heads with the more conservative leaders in parliament and in government. Um, von Bismarck, was the chancellor in Germany, and he had to contend with these kinds of strikes, which were developing at the close of the Gilded Age. One of the things that he needed to contend with was maintaining his power. To prevent him from being essentially thrown out of office via voting, there was voting at the time, he decided to engage and capitulate to the need of workers to have some kind of health insurance. So Otto von Bismarck created the first public sickness coverage for the working class. This was compulsory. And it was compulsory for both employer as well as worker, using guilds and sickness funds as the base of that. This first national health insurance essentially provided unrestricted visits to doctors. Again, care was relatively inexpensive. Unrestricted medical care, again, relatively inexpensive. Paid sick leave if one was ill. And so these were dramatic changes for the worker. It was rapidly embraced by Scandinavia and many European countries, as well as Britain. So again, in this progressive era where Teddy Roosevelt was the trust buster in the United States, he was basically initiating some kind of regulation and reforms on workers' hours, but and on the ability of companies to consolidate with one another without governmental impact. A lot of changes were happening during the Progressive Era. But in Britain, national health insurance was happening. Lloyd George created the National Insurance Act, again, similarly funded by employers, government, and wage earners, again, as administered by the friendly societies of the age. So this rapid sweep of progressive law was worldwide and was a time of social activism and political reform. These are suffragettes. Remember, women didn't have the vote. This was a time of rapid change. The other change that was happening, by the way, were the role of journalists in shining light on, on
Dr. Dolkart, I think you're muted.
wondering how that got lost. Usually my internet's relatively stable. Was there a lightning strike out where you are, Natalia? Did you just lose me?
Yeah, I think we all lost you for a second, right when you're talking about shining light on.
Yes, the muckrakers and the journalists of the age. All right. It says participants can see my screen. Is that true? Oh, good. All right. Anyhow, whoops. You can see my desktop. Um, oh my goodness. I need some coordination here. I'll blame it on jet lag, but I'm not sure that's true. Ah, get over there. Oh gosh. All right. Lots of changes happening in the progressive era. This is a picture of the meatpacking industry. And actually, the precursor to the Food and Drug Administration was created in 1906 under Theodore Roosevelt. And it was actually created to monitor both food as well as patent drugs, over-the-counter drugs that were commonly prescribed. He actually did propose a health insurance to be administered by industry, which was compulsory. But in that era, despite the progressive age, it was struck down by a very powerful industry. Department of Labor was created during this time for occupational safety. Remember, children were working during this era, as well as and hours were unregulated. People could work 12-hour days, had maybe one day off on Sundays. So there was a necessity to create some controls and reforms. Um, anyhow, the Veterans Administration, particularly after World War I, was created during this time too. So some of the origins of what we came to, what you know of, had its origins in the at the close of the Gilded Age. I'm sorry, folks. I'm really struggling here. It's a little bigger. All right. So, what was happening in Europe versus the U.S.? A lot of political unrest. The United States was fortunate to have labor stability for whatever reason. And the other issues in the United States was labor unions were starting to develop, and they had no interest in government superseding their ability to provide for their workers. They wanted to maintain power. So one of the earlier unions, the American Federation of Labor, was actually opposed to any national health insurance. Remember, the Bolsheviks took power in Russia in 1917. Lenin took office, and there was fright for a lot of other societies, and there was a distrust of socialism. We went to war with Germany and the Axis, and there was anti-German sentiment, and most importantly, opposition by the AMA led to no expansion of insurance, health insurance by state or federal governments, in contrast to Europe. The commercial insurance industry was just getting off the ground. It was barely able to assess how to create premiums and how to calculate how to provide care. That changed in decades to come, as we'll see. Again, the trustbuster of the Gilded Age, Teddy Roosevelt, did support national health insurance, but subsequently, Presidents Taft, Harding, and Coolidge found no role for such outside of commercial insurers. And here, how many of you have heard the chief business of the American people is business? Have you heard that? Yeah, I mean, so that was the conception before the crash of 1929. We mentioned disability insurance as the major necessity for most Americans. And disability insurance was popular, but at low demand because it was often unaffordable. What happened was workers' compensation law, and this was state by state. So people could now receive payments if they were disabled or lost their job or injured, and was accepted by industry. So workers' compensation, which was state-based, was widely expanded throughout the United States, such by 1948, every state had workers' compensation. The insurance industry, again, was starting to develop some of the skills in determining, well, if you have this, if you're of this demographic and you have these illnesses, we can calculate how much you should pay us so we can make a profit and we can cover your healthcare costs in years to come as you grow older. And indemnity health insurance was the major form of insurance during this time. Well, so in Canada, insulin was discovered. And by the way, the patent for insulin was $1 sold to the government of to governments throughout the world to create insulin. Fleming discovered penicillin. Surgical techniques advanced. There were some early antibiotics. So new care was progressing. Treatment became more pervasive, but it also became more expensive. Still, by the 1920s, people were paying for medical care out of pocket, but because surgery was becoming more widespread, hernias were repaired, tonsils were removed, in addition to medical emergencies, it was harder for people to predict their future costs. And as a consequence, medical insurance was now becoming part of the scene. So, why do we have medical insurance? If you cannot know, if you don't have a crystal ball and you cannot predict how much of your income needs to be saved to stay solvent during an illness, you want to pool, you want to reach out to a company that could provide risk pooling. Basically, an insurance company allows shifting that loss from the individual to themselves by bringing on a large number of enrollees. And the amount of money that the enrollee would have to pay for their care would be determined by the size of the risk pool and whether various services were excluded or covered. And the medical loss ratio. Did Dr. Malik discuss that yesterday? Is that a term you heard? Maybe not. Anybody hear the medical loss ratio? That terminology before? Good, you're in the right course. Medical loss ratio refers to how much of a premium, how much of the dollars collected by insurance companies actually go out to pay for medical care. It's called medical loss, which is ironic. I mean, they're in the business of providing medical care. But if you're a for-profit or non-for-profit, if you're an insurance company, you want to stay solvent. So you have to determine how much of your premium is going out to be expended for appendectomies, for knee replacements, for etc. Does that make sense? Is that any questions about medical loss ratio? It's how much of the premium, how much of the total collected dollars from enrollees gets spent on actually medical care, rather than building new buildings for the insurance company, profit for the CEO, etc. Does that make sense? Again, if you're an insurance company, you would like to enroll healthy enrollees, so you don't have to have much medical loss. And the selection by advertising, for instance, in the more modern era, or creation of policies that appeal to people who are healthy, such as membership in a gym. Picking healthy enrollees is called cherry picking. If you exclude various things in your medical policies, make the cost of HIV drugs, for instance, exorbitant, or or not cover the cost of medicines for congestive heart failure, etc. If you exclude various conditions, that's called lemon dropping. Just some terminology you're going to hear. And of course, anyhow, these are some of the early types of insurance in the 1920s that were developing for medical care. You don't hear about indemnity insurance very much anymore. They're very uncommon these days, but they were the major form of insurance for most Americans in this era. Basically, you paid a premium to an insurance company, and if you you needed your tonsils removed, you would send the bill from the doctor to the insurance company. The insurance company would subsequently pay all or a portion of that bill. They didn't care who the doctor was. They didn't need to assess the quality of that care. They basically just reimbursed the medical expense. The insurer could exclude various services, as we talked about in this era, pre-existing conditions. They could set an overall cap on how much they're going to provide for services for profitability. Now, again, if you can't afford a Cadillac insurance, you can just get a very inexpensive form of insurance that would just cover, let's say, catastrophic care. That would be affordable. It would not necessarily result in your going bankrupt, although, as we will see, that often would be the case. But the ideology of allowing an insurance to be fitted to a person's, quote, need, which in this case means income, fits with the concept of indemnity insurance. The terms medically underwritten versus community rated premiums, was that addressed yesterday? It may not have been discussed yesterday because I think we're on a broader level of health policy probably yesterday with Dr. Malik's talk. So this is again insurance terms. Medically underwritten or actuarially fair means that if I want to get health insurance, the health company is going to ask me 1,000 questions about my medical history. Do I have a history of high blood pressure? Do I have diabetes? Have I been hospitalized in the past for anything? What's my age? What's my demographic? And they will put all of these, again, they started to be able to create coherent formulas and mathematical actuarial systems to identify how much I should be paying for my premium based on my individual experience and healthcare history. They could also say, no, you've got too high a risk. I'm not going to provide coverage to you. That is in contrast to community-rated premiums. Again, this is calculating how much a premium should cost the enrollee. Community rating premiums takes all individuals within a large pool, some of whom have high risk, some of whom have low risk, and consolidate that to create one, relatively one cost of a premium for all individuals. In a sense, if I'm very well, I'm going to be paying more than I would otherwise because I'm paying for those patients with end stage, COPD or malignancies or chemotherapy, etc. So the well do subsidize sicker people, but on the other hand, it keeps the cost down for the entire population. And this is typically used by Blue Cross Blue Shield. It's the system that goes into Medicare, the Affordable Care Act, and all European systems. Does that make sense? We'll touch on that again, but any questions about how premiums are calculated? I think this is new to most of you. You're studying histology. You're studying a lot of stuff that has nothing to do with medical insurance. But I think it's worth knowing this because any questions about this? We're good. It's 9:52. And we are going to move on unless do people need to take a bio break or people need to move up and do some yoga or some stretches. Where are we? We're Anana, you're okay to move on. Do I have a consensus? Okay. So let's move on. What happened in American history? The Great Depression. Lack of regulation in the stock market, and this created spin-offs of various innovations in a nonprofit world. We'll touch on nonprofit prepaid insurance models. Again, many of you have heard of HMOs and managed care insurance, which is the predominant form of insurance today. Its origins were back then. Most important, I think, from the session coming up, and I'm going to try to move through this, is the historical events linking the U.S. Health insurance system with employment. So let's move on. Depression. Again, folks had overinvested in the stock market. Remember the Roaring '20s. There was a population of folks who were making money hand over fist by speculating in industry and the stock market and the insurance. No banks were allowed to sink their money in the stock market, which has huge variability. There was no conception that the stock market could do anything but go in one direction, which was up. Suddenly, there were some constraints on profits by industry. It was recognized that people had overinvested. The cost of the stock was not proportionate to the earnings of those companies. There were grim forecasts that entered into the media of the day. There was a run on stocks. People were locked out of their money in the banks. The bank did not have the money. There was no regulation to make sure that money existed. People went to their banks in long lines and could not, became destitute. So there was general strife, insecurity, unemployment, and the government was now in responsibility for providing work. The New Deal included unemployment insurance, assured that on a national level. It assured old age pensions for those who are not able to work in the way of Social Security. It was widely accepted that really day-to-day uninsurance benefits were more important than any kind of national health insurance. The CCC and various public works were sank into building Grand Coulee Dam or Glen Dam or major national projects. And this New Deal was passed without including healthcare. Again, unemployment was the key issue. healthcare only accounted for 1% or less of the gross national product in 1936. It's not like there weren't efforts. There were political efforts to put in a compulsory national health care program, but this was not accepted in 34 and 38. Again, the AMA was still in power, although one of the things that was happening during this time is when a society was no longer able to afford medical care, they were not filling hospital beds for elective procedures. You didn't go to the hospital unless you were at death's door. So you didn't have your hernia repaired. You didn't have your tonsils removed. You didn't have orthopedic procedures. There weren't elective operations. Hospitals were suffering due to widespread poverty. And as a consequence, some innovative forms of hospital insurance were developed that were accepted by the AMA and accepted by physicians. So Justin Kimball, who had previously been an educator, became the manager of a hospital floor in Baylor in Dallas, Texas, and he designed a nonprofit plan to fill those empty hospital beds. He basically allowed nurses and teachers to pay in a prepaid fashion 50 cents a month to cover all their hospital care for up to 21 days per year. This was a novel conception. Now, the hospitals could charge what they wanted, but you still had that care provided. The plan was responsible for negotiating with the hospital to keep those costs covered by the prepaid plan. This was the origins of Blue Cross, which was a nonprofit prepaid insurance for hospital care initially for 1,500 teachers, but it rapidly gained acceptance throughout the United States. When I was growing up and that pediatrician came to my home to keep me out of his office and manage my measles, my folks had Blue Cross Blue Shield. So it was actually rapidly accepted throughout the United States. Again, the AMA accepted it because they realized that hospital beds were not getting filled. Blue Shield became the first nonprofit plan to cover outpatient hospital fees. It was, again, rapidly accepted, and it used community rating and local community boards. The other important thing is local communities had impact on who was on those expenses and where the expenses were going. Blue Cross Blue Shield ultimately merged in 1974. And there are other rural medical cooperatives which developed, the conception of capitated payment for physicians started to grow. How many of you have heard of capitated payment? I see some nods, a lot of shaking no's. Jay says yes. Oh, great. So again, you're in the right course for these elements. So capitated payment, we'll get to. By the way, during this era with Blue Cross Blue Shield, there was still indemnity insurance, but by 1971, Blue Cross Blue Shield, a nonprofit, community-rated, locally controlled form of insurance, had many more lives, 71 million lives, compared to 48 million lives in Prudential, which was the largest indemnity insurer. So capitation, that's essentially a payment arrangement for healthcare service providers. Now we're becoming providers. So there weren't physician assistants of the era, but for nursing care and for doctors, it set a set amount of payment based on how many persons you were responsible for. So, sorry, a set amount of would be provided per enrolled person. If I were a doctor and I had a panel of 1,200 patients I'm responsible for, I would be reimbursed based on the size of that panel over typically on a monthly basis. And I would be reimbursed for that panel whether or not the person came in to see me or sought care. The amount of payment per person, that remuneration, was based on what was the expected health utilization of those patients. With patients generally having various ages, the payment would be increased if they're older or if they had more medical conditions. So a HMO is basically a capitated insurance entity that also, by the way, hires the doctors who are responsible for that care. Now, that sets up some intrinsic conflicts. If my salary is dependent on controlling costs, I might serve as a gatekeeper. You may have heard that term, that I might be actually underserving my patients by limiting their services. Um, so the but large industry basically was the origin of capitated healthcare. Um, in California, many of you have heard of Kaiser. You know it as Kaiser Permanente and as an HMO today, but it had its origins with its coverage for workers in shipyards and steel plants. It was a huge industry that was large enough to hire not only its own docs, but build its own clinics and including a hospital adjacent to the shipyards. And it would use this capitated basis to develop these health maintenance programs. And ultimately, it was opened. What was experienced was that you're really not taking good care of your work unless you're also taking care of their family. So ultimately, although it was initially designed just for the worker, it came to enroll families as well. And actually, for those of you who have interest in family medicine, Kaiser developed that field of family medicine, the interaction between people within a particular family and the necessities that were individualized for different people in that family, pediatrics, older adults, etc. So here's just an example of a ship being released in San Francisco. These direct service plans, or HMOs, came to have different models. Remember, I think we're here until 10:30. You asked for this, but I think it is important stuff to know about. So we have a staff model health maintenance organization. This is basically a clinician group that's integrated into the same corporation, the same insurance organization that is enrolling the subscribers. So you're working for a large health maintenance organization that is both the insurance entity as well as the clinical care. The good element of that is the HMO is responsible for quality of services. Instead of not caring how good the doctor was and just providing reimbursement, it would make sure that the care was adequate, and it emphasized preventative care, realizing that if you can prevent the stroke by managing the hypertension, actually in the 1940s, there wasn't much for hypertension, but if you can prevent the illness by improving the work setting or wearing a helmet or whatever it was, you can limit your costs. So it was directly responsible for quality of services, and it controlled financial risk by regulating the facility and equipment. That is, you had to go see you had to be hospitalized with their hospital rather than any hospital in San Francisco. It would also limit the subscribers to the group within that group. And it was comprehensive. It did look at all the elements of care that might go into illness. And the goal was to treat illness at an earlier stage. It limited costs at the point of treatment and by restricting unmitigated services with any provider in the city. How many of you have had any experience with your parents' conception of HMOs? What's your take on HMOs? Yeah. Any connotation, what comes to mind about health maintenance organization? Zachary, yes.
I actually, most of my life, I was actually a Kaiser patient.
Uh-huh.
So very familiar with HMOs.
Hmm.
It kind of just makes the PCP more like you said, like a gatekeeper, especially since we prioritize specialist care. So even though you do have like the same PCP, you go to see them maybe for like your annual checkup, but other than that, you're kind of just looking for a specialist referral. But I had a positive experience. It's obviously the cheapest plan in Southern California. And at least in Southern California, the hospital network is so extensive that you don't really have a problem finding care, and navigating care is really easy, which is probably a problem with other HMOs, finding out who your HMO is contracted with. But Kaiser, super easy. If it has a Kaiser logo on it, they're going to pay for your care. So
Sure.
I had a positive experience with it.
Glad to hear that. I think that was not uncommon. People did have positive experiences. There is that di divergent element that you are getting good comprehensive care. In fact, they first developed annual wellness visits that didn't exist in medicine until HMOs actually. It was their origin. Um, but so there's positive elements. And unfortunately, as care has become more complex and more expensive, a lot of folks have a connotation of the gatekeeper aspect of things. I need my doctor, send me somewhere else, and they're resistant to doing so. And that was a problem in the 1990s. What happened was when many of the non-for-profit HMOs were deregulated, such that you could become a for-profit company nationwide and sold with stock on the stock market, profit became very important. Quarterly reports became very important. So ratcheting down the utilization was actually being devoted towards profit in part. It was problematic for many Americans during the 1990s. It was a time when pre-existing conditions were excluded and really resulted in some tragedies. The last session of this talk today, I do want to touch on how America came to link health insurance with employment. That's wartime inflation and employee sponsored insurance. So there were a few corporations that did create care coverage, as we were talking about, prior to World War II. But most people had no linkage with indemnity insurance between their health insurance and employment. What changed was the world suddenly plunged into war. Pearl Harbor plunged America into that war. And suddenly the federal government had to ramp up industry to create ships and tanks and airplanes and jeeps. The government had to print tons of money, and that was pumped into the industry of the economy. All this money is being sunk into various corporations, and it was obviously coming from printing of money. We didn't have new gold reserves or new expansion that was of taxes. So workers were very well paid in those industries in the United States, since the workforce was limited because so many soldiers were serving overseas. 10 million soldiers went overseas, and the people who would usually be working in those factories were no longer. And so those workers were being competed for. If you made tanks, you wanted your workers. If you made Jeeps, you wanted workers. If you're in the same city, you're competing over the same worker. You're going to raise their pay. However, the Rosie the Riveter, who's getting that pay, were not finding places to spend their income on because there was regulation and quotas. You couldn't find nylons. Remember drawing that line up the back of people's calves? I'm not sure if you've ever seen a movie where women used to do that to pretend they were wearing nylons because you couldn't find clothing or fruits or various luxury goods. So what was happening was this real concern about inflation. Most economists and people had viewed what happened in the Weimar Republic in Germany after World War I, where people were walking around with wheelbarrows full of money that was worthless. Inflation was a real and valid concern when the government was printing money and there was nowhere to spend it. So basically, to fund the war and soak up that unspent salary, new taxes were, that's where taxes developed during World War II to automatically be deducted from payroll to pay for some of that printed money. And by the way, taxes were first created during the Progressive era as the Gilded Age came to an end. But that was not sufficient. War bonds were promoted to divert the excess salary that was into savings. That was not sufficient. And what was necessary was what's called Wage Stabilization Act. So basically, wages were fixed for various industries. So work benefits, however, when that company that makes Jeeps is competing with that company that makes insignia patches and company that makes ships, the benefits, the perks were not limited, just the wages. So contributions by an employer for health care was one of those perks. And law was written such that contribution by the employer for their workers' health care would be tax deductible for the company. So health insurance became a popular competitive perk for attracting workers to companies. Unions loved it because it helped, basically, it was an equivalent of a salary increase, but these efforts managed to control inflation. And that was the origin of employee-sponsored insurance. When those 10 million soldiers came home, all of a sudden, those wartime wage and price controls were abolished. War's over. We no longer need wartime wage controls. Inflation rebounded. Unions were actually quite strong during this time, and they demanded totally new contracts. Employers could no longer offer tax deductions for health benefits, and there were multiple strikes in the US. Remember, we saw how this affected politics and health insurance in Bismarck's Germany. Now this was convulsing America after World War II. Um, um, I want you to consider that for a second. I just do want to have an update on the AMA. And remember, a lot of Black Americans served in the war. They were in segregated platoons. Often there were a few that were not, but they came back from the war, having served their country, but still in a nation enveloped by racism. The National Medical Association again tried to get enrollment in the AMA, still not adopted. Um, During this era um, of World War II, hospital and depression, hospitals were not being built. Remember, the hospitals were empty. There was no money to be spent on hospitals. There wasn't actually enough beds as people started to have more insurance from their employer, and the economy started to take off. People didn't have hospitals. So the Hill-Burton Act was enacted. This was a Truman initiative for construction for federal support in constructing new hospitals and healthcare facilities. The Southern Democrats insisted that the bill needed to have segregation built into it. So it was separate but equal in hospitals and facilities. Ultimately, 20 years later, that element of segregation was overturned in federal court. Now, that was not Brown versus the Board of Education happened in 1954, but this allowing the federal government to provide separate hospitals for Black folks versus Caucasians was overturned finally. What we will learn about with Medicare is, again, it had a positive impact on overturning segregation within the hospital. So that was just a diversion on some of the events happening simultaneously. Following the war, again, post-war, our friend Harry Truman proposed a fair deal, which is government-funded health insurance via a 3% payroll tax, which would pay for medical, hospital, and dental care for 80% of our population. That should be a percentage sign. And all eligible citizens would be required to enroll. This is what's the case in Europe. This is basically how many national health insurance programs work overseas in other countries. Most Americans then, as now, were in favor of this. Let me ask, before we move forward, how would you view how the public viewed the role of government following World War II? That is, there was the Great Depression, World War II, the New Deal. How do you think most Americans viewed the role of government then versus now in what you see in how society views government interactions or responsibilities? And I'd like to hear from folks who have not spoken. So I'm not picking on you, but the time has come to pick on you. So Shrindi or Kenzie or Lauren or Ariana, can you guys come to the plate? And so the question is, how do you think the vast majority of Americans viewed the role of government in providing public good then versus now? How about Shrindi? Can I pick on you? Okay, okay, thank you. Well, just what comes to mind?
I mean, it seems like previously it was relatively favorable. I think if you polled the general population now, it might be similar of people being generally in favor of some kind of like universal support. Um, but also I'm not 100% sure on where people fall on that today.
No, and you're absolutely right. It's very interesting. Polls have been done. Gallup polls were done just 2 years ago. Um, and more than 60% of Americans were in favor of a national health program, of a governmental responsibility. So that's interesting that really hasn't changed. But Lauren, in terms of how and again, it depends on where you're getting your news or getting your perspectives, and um, where's your home, Lauren? Where did you grow up?
I'm in Southern California.
Yeah, also Southern California. So I'm not sure. Well, what is your well, actually, there's some very conservative areas of Southern California. How would you say the folks that you hear from or you interact with or read about view government role in public good, not just healthcare, but just it's what's your take on that?
Yeah, it's kind of funny. I live in a city where I think it's more on the conservative side. It really depends on what part of it you're in, though.
Mm-hmm.
So I worked at two different hospitals, and one was definitely the patients I worked with were very much opposed to the idea of government involvement in their lives.
Mm-hmm.
But then later I worked at a community hospital, and the sentiment was completely different there. So I it's hard to say because I've seen both opinions really. But I think in general, a lot of adults around me seem to favor more hands-off.
Mm-hmm.
Um, but
And,
yeah,
and
I'm not sure.
thank you. And by the way, even though the polling is unchanged, I think society has changed. What you're pointing out is that we live in a more libertarian society. And we'll talk about neoliberal elements of how the world changed in decades to come. Yes, Mackenzie.
I was also thinking kind of build off what Lauren said. I feel like I've talked to people who seem a little more libertarian and they're more interested in a more hands-off approach, but I think there's a little bit of cognitive dissonance there because they also complain about the roads and say we should get the roads fixed and stuff like that. And they want the government intervention and the government support without necessarily acknowledging it as government support a little bit at times. But that's what I've noticed.
No, again, important observations. People view the pothole that bumps them when they drive over it as a government responsibility, but their neighbor who's dying because they couldn't receive medical care is less their responsibility. Interesting in terms of also cohesion of a society and what are the priorities of a society, how that might have changed. Yes, Anana.
Yeah, I really agree with what everyone has pretty much said. I feel like post World War II, people really trusted the government. I mean, we just beat fascism. Like, yes, our government's amazing. Like whatever that we do is grand and amazing and whatever. But I feel like now there's a lot more skepticism and it's like, oh wait, are we the fascists now? Like what's happening? And there's a lot of, partisan divides, and people do want to have a government that provides, these safety nets, but based on the system that has been letting its citizens down so often these past couple decades, I feel like in order for they want that safety net, but they don't trust this government to provide it. So I feel like we need a little rehaul, if that
That,
makes sense.
and that's, thank you. An important point that you made was trust in
Yeah.
government, which is an important issue when it comes to considering things like a national health insurance, making the decisions for what gets covered and what doesn't. Now, Medicare, as we will see, is the most well-respected form of health insurance in the United States. And it does exactly that. It decides based on science and it tends to be fairly liberal, but we'll cover this and not cover that. Um, um, However, the expansion of a national health insurance to all Americans is going to meet resistance in a way that other countries, and given their community perspectives and perhaps ancient history going back to the Middle Ages of guilds and other elements of responsibility, will be more difficult to perhaps be accepted here. I think that's an important point as well. So things that we will tackle and touch on in this course. Any other thoughts? Have we lost somebody? Are we still here? Maybe just my screen. So, whoops. I think let's move on a little bit. So in Britain, going back to the 40s and post-war World War One and World War II, the United Kingdom actually in this era expanded the national health care program to the National Health Service. And as we'll see, that is a true socialized beverage model. Many European countries were expanding their health insurance through Bismarck models or the use of health insurance as intermediaries. But elsewhere in the world, health insurance was becoming a governmental responsibility. Here in the US, despite positive polls, the AMA, Chamber of Commerce, American Hospital Association were very effective in controlling public opinion. Stalin had just dropped the atom bomb. There was a real scare of socialism. And although, by the way, Truman's program was not socialism, again, it was not providing direct salary to physicians. It was not providing the cost of building the hospitals. It was assisting that with the Hill-Burton Act, but it was coming mostly from communities. Doctors were still getting paid through insurance companies. Despite all that, I'm sorry, doctors were still getting indirectly paid via like Medicare, but not directly salaried. Despite all that, it was shot down. And unions, again, still wanted to provide benefits and not allow the government to assume that role. We're talking about these crippling strikes. Conservatives came to control more power in Congress. Taft-Hartley Act was created, which limited the power of unions to do elements of collective bargaining. But again, in terms of employee-sponsored insurance, although unions could only control certain elements of benefits, health benefits were carved out such that unions maintained power to continue to create that perk for their union members of health insurance covered via the employer. Ultimately, the fair deal of Harry Truman was shot down actually by Southern Democrats. And Southern Democrats in Congress feared national health insurance because they feared it would outlaw segregation in hospitals, which actually came to pass. As a consequence, in that vacuum, employee-sponsored insurance became the modus operandi for workers in America who had such employers to receive their health care. So post-war, employee-sponsored insurance grew rapidly. This was a time of great economic growth in large industry, U.S. Steel, GM, AT&T. Both employers as well as labor favored employee-sponsored insurance. 75% of adults less than age 65 had their health insurance through their employer. The veterans programs were expanded again with the GI Bill and the Veterans Administration Hospital, with all those veterans, with all those soldiers coming back from overseas. And in this era of consumerism, there was a book called The Affluent Society, published by this economist, Kenneth Dolkart, that talked a lot about how we were seeking how we were seeking new products as proposed by advertising, this vicious cycle between advertising industry and public need. And again, doctors were still well respected in the 1950s and 60s. Dr. Kildare and Ben Casey were some programs I watched growing up. The employer really negotiated with the third-party insurance companies to create the premiums for its workers. We talked about Blue Cross Blue Shield being the largest third-party employer. But remember, 25% of Americans did not have health insurance. There was this other America, or poverty. We had lots of socially invisible Americans who were not employed by large wage, by legacy corporations, or they're not employed at all and they're living in poverty. The folks who did not have an employer who offered health benefits had few options to afford health insurance. And among those who did not have health insurance were the elderly. So in 1964, throughout this time, 50% of the elderly had no health insurance for hospitalization, and a quarter of, and again, the elderly were considered age 65. A quarter of those over age 65 had no health care whatsoever due to cost issues. Remember, the life expectancy in 1964 was 67 years of age. You died at 67 for the vast majority of Americans. Modern science has moved on and addressed the impact of modern society on cardiovascular disease and other disorders. But the vast majority of Americans did not have health insurance if they were elderly. And part of the reason was if you're in health insurance, you could not afford to provide it. You would go broke if you would be paying for the health care of people who had a high risk of being hospitalized. We'll talk about this a little bit more in the next session, but I'll just share with you that that was an era where health insurers could not afford to cover insurance for the elderly. Today, health insurers cannot afford to not cover health insurance for the elderly due to the handouts of Medicare Advantage for the insurance industry. We've come full circle.